Okay, I think we can start. Welcome to this third session of our training series, Introduction to Air Pollution Epidemiology. We're happy to have all of you. Couple of housekeeping announcements as we begin. As always, you can share your name, organization, where you're from in the chat. We'll be receiving your questions through the Q&A box as we go with the session. The training slides and the webinar recording will be available on our website. So I'll take a few minutes just to explain to you where you can find that on our website. We did get a lot of questions last time where the slides and recordings are. So if you visit our website, the link is just below there, healtheffects.org. We have a news and events tab. If you click on that, in the drop-down menu, you'll see meetings and webinars. And this virtual training series is the first one that you will see on that page. So on the page, you will have access to the first two sessions, the slides, the recording for the first two sessions, and this session will be included in the course of this week after we are done with the session. So welcome you to refer to those that material, and it will be there beyond this virtual training series. So you can always access it and at any time. So welcome. So today we'll briefly go through HEI as we build to our training series and why we are here today. So a few words about HEI. We are a nonprofit whose mission is to provide impartial science that informs decisions and fosters a healthier environment for all. We do this through three programs at the Institute. We have an environmental health program, an energy program, and a global initiatives program, which is the program that's bringing you this virtual training series. So our global initiatives program works across various regions, Africa being one of them, South Asia, Southeast Europe. We do this through several pillars. You may be already familiar with our State of Global Air initiatives that brings you the annual State of Global Air report. So using really GBD data or high quality impartial data to bring you air quality exposure and health impacts on a regular basis. We also do have a scientific capacity pillar where we conduct locally relevant research. In the case of Africa, we have an ongoing request for funding open for East Africa that we are currently in the process of selecting studies, and hopefully studies will begin in the beginning of January of next year. Similarly, we do have from time to time, do evidence synthesis. What you see on your right, I believe, is a recent report that we did launch in April 2025 on the health effects of air pollution in East Africa. We're just beginning a similar report for, this one covered 8 countries in East Africa. We are beginning the process of a similar report for West Africa, covering 16 countries. And hopefully we'll launch that sometime next year. Finally, but not the least, you also do support collaborative networks, such as the Africa Clean Air Network. And we have the its annual convening, the Clean Air Forum, in about a month's time in Pretoria. Looking forward to seeing most of you, if not all of you, at the forum. So this is really bringing together different groups on the topic of air pollution, connecting researchers, policymakers, practitioners, and different communities around the topic. So why are we here today? So this training series is part of a sort of scientific capacity building initiatives. We've had 2 sessions where we've gone through monitoring. The last session we went a lot into the exposure, how that's characterized, and the sort of micro environment, personal exposure as well. Today's session is really aimed at looking at how that air pollution that you're exposed to leads to some of the sort of health outcomes we see and report from time to time. So we're going to go a little bit into the basics of the air pollution epidemiology. And we have a last session in 2 weeks' time at the end of June, where we're going to see really practical examples of how different groups in different localities are applying this in designing air pollution epi studies. So as usual, our program is same as first two sessions. We'll have a brief welcome, which is what I'm doing now. 50 minutes or so lecture style sort of presentation. And we want to leave time for also discussion, questions and answers that you may have. And then we close the session. So today I am the host, and our speaker for the day will be Professor Jill Baumgartner from McGill University. She is also a member of our Global Initiatives Oversight Committee. So I will hand over to you, Jill, for today's session. Welcome, and I'll stop sharing my screen.
Great. Thanks, Victor. And I will share my screen, assuming this works. All right. Hopefully everyone can see my screen.
Yes, we can see your screen.
Perfect. Okay, so I was tasked with giving everyone an introduction to air pollution epidemiology, and I'll start with the caveat here that this is intended if you have already had an epidemiology kind of 101 course. This is probably going to be review for you. So if you have a strong background in this topic, a lot of this may be stuff that you've already covered, but it's intended to just give a sense of the kinds of things that, well, first of all, what is air pollution epidemiology, but what are the kinds of things that we tend to think about when we're designing these studies for causal inference, because that's the goal. We're trying to know that air pollution is a cause of these health outcomes or that an intervention provides a particular benefit. And what are the things that we think about in that context? Just a little bit about me. So, I'm a professor at McGill University in the Department of Epidemiology. And I also direct the McGill Center for Climate Change and Health. So my research, it starts at sort of more the community side of things where we work with stakeholders on co-production of research. So designing our studies, designing the measurements, all the way through to the policy translation piece of the work that we're doing. We look at the health impacts of different environmental exposures. So in the example here at the bottom on the right, this is work that was led by Anna Palmer, who's now a postdoc at Columbia, looking at the impact of extreme weather and specifically looking at flood exposure and educational outcomes in a global analysis. We also look at interventions and policies and how those affect health. So, one of the things that I'll talk about a little bit later is a quasi-experimental study that we did evaluating the impacts of Beijing's clean heating policy on heart attacks and also on blood pressure, which was part of an HEI-funded study. And we do a bunch of work looking at exposure. I'm not going to talk about that because I know you discussed exposure quite a bit in your last session. But essentially, what my group is often trying to do is understand how environmental exposures affect health outcomes, what are the benefits or even unintended consequences of interventions. And we do that in partnership with key stakeholders that are engaged and involved in the kinds of topics that we're working on. So for today, I have three main learning objectives for all of you who are here. So the first is that I want you to be able to describe what is air pollution epidemiology, what are its goals, what are we trying to accomplish. I want you to be able to explain the concept of exchangeability and why we care about that for causal inference in studies of environmental risks and health, and what are some of the challenges to exchangeability that we have to try to deal with in the way that we design studies, and how those study designs can influence our causal interpretation of the relationship between air pollution and health and the research that we're doing. A lot of my talk is going to be on study design. And I just want to start out by saying there is no such thing as a perfect study design, right? And I think this is maybe the most important lesson that you could learn. The perfect study design does not exist. So all of the study designs that I'm going to talk about, all of the ones that you'll learn about, has a set of limitations. And it's our responsibility as researchers with integrity to understand and acknowledge the limitations of the research that we're doing, but also to be transparent about them, right? So limitations are not something that you want to hide. You, when you're conducting your study, you want to know every single limitation or possible limitation that's biasing your results or potentially biasing your results. And you don't want to hide those. You want to be transparent and discuss with the readers and the knowledge users that are reading your study or listening to your talk what those limitations are and what the implications of those. So I'll start out with that, and then we'll kind of dive in. So what is environmental epidemiology? So this is a subset of epidemiology that is aiming to understand or study how environmental exposures, so this can include things like air pollution, chemicals in the environment, even climate factors or extreme weather, how those influence health patterns that we observe in a population. There's lots of different books that have been written about environmental epidemiology. And so if this is something that you're interested in, then definitely think about some of one or several of these books as ways that you could learn a little bit more about this topic after this talk. And ultimately, what we're trying to do is inform environmental policy and risk assessment and public health strategies for prevention by doing these kinds of studies. Air pollution epidemiology is kind of a subset of environmental epidemiology on its own. And in some ways, it's a little bit funny that we refer to something called air pollution epidemiology. We don't really have sanitation epidemiology or green space epidemiology. And the reason why I think we have this subfield called air pollution epidemiology is really because it's one of the most widely studied environmental exposures. It's ubiquitous, it's modifiable, right? You can reduce exposures and reduce emissions from air pollution. And it affects a range of health outcomes that occur throughout the life course. So it's a really important environmental exposure. Um, it is this subset of environmental epidemiology, so it's still sort of doing the same thing that I talked about with epidemiology or environmental epidemiology, which is that it's looking to understand the distribution and determinants of health in populations, and that we're looking at its application is intended to improve health and reduce health inequalities. Um, but it focuses on air pollution and air pollution related interventions as a determinant of these health outcomes. So what's the goal of air pollution epidemiology? What are we actually trying to accomplish with this? And really, there's two things that we're trying to do. We want to provide evidence for establishing causal effects of air pollution on health outcomes. And then the second piece is that we want to understand the health impacts of air pollution interventions or policies. So the key thing here is really this causal effects piece, right? So when I'm talking about causal effects, this is a process of inferring, and I'll talk a little bit in this talk about what I mean by that inferential piece of inferring whether observed correlation in your data reflects a causal relationship based on both evidence and reasoning. Right? Um, so this rests on this thing called the counterfactual model. And so when epidemiologists talk about causal effects or causal inference for any type of exposure, so not just air pollution, this counterfactual model is usually the one that we're thinking about. So that's the foundational piece behind the things that when we're referring to causal inference or causal effects. Um, so this was developed by both philosophers and statisticians, and it's now really the dominant model for epidemiology, but also in most other scientific fields, right? So the causal inference is not unique by any means to epidemiology. And it's not a new concept. So, Scottish philosopher David Hume in the 1700s suggested the first iteration of what we call the counterfactual condition. which is a hypothesis about what would have happened under conditions contrary to the fact. So counterfactual, right? And so he wrote, we may define a cause to be an object followed by another, where if the first object had not been, the second had never existed. And that's essentially the same definition, right? When we think about causal inference, if in the absence of exposure to air pollution, would these health outcomes have developed or this distribution in a population still exist? All right, so let's pick apart this a little bit. So when we talk about cause, and I'll open this up to the chat, what is a cause? So when you think about a cause, what do you think about? And feel free to just write your thoughts in the chat on this. So what's a cause? Okay, originator. What else? When you think about cause, what do you think? What does it make you think about? Okay, something that leads to an effect or a particular outcome, an action that always leads to effect, something that produces an effect, trigger a reason, something that serves as a precondition for the existence of another event, why something happens. Yeah, so I think these are all in some ways like this is because this is a very intuitive concept. Like we've been thinking about causes, and it's actually some of you may have small children, but I thought it was always really incredible when my kids were growing up, and particularly when they were in those toddler years, like 2, 3, and they were figuring out causes too. Like my son would take a cup and he would drop it, and then he'd say, happened, right? And this is him figuring out that, if he picked up the cup and dropped it on the ground, that cup would break, right? So, and he was kind of figuring out the cause and effect. Picking up the cup and dropping it would lead to breaking. But it took a while. So early on, he would just leave the cup on the ground and then just say to me, well, it's there. But the cause piece of it was not, he thought he could kind of get away with that, right? Because I didn't see it happen. So there was just a cup that was on the ground. And so you can see that in some ways, it's this really kind of simple and an intuitive thing or idea, right? A cause is just a thing or things that make an event happen when and how it does. And then the effect, as I think many of you are writing about in the chat, is the result. And so together, cause and effect explain why things happen, right? And again, we use this kind of thinking all the time. So sometimes we're trying to understand, the physical world that we live in. We're trying to understand our emotions or our behavior, and we're constantly trying to tell the difference between things that are just connected and things that actually cause one another. Um, but then when you start thinking about cause and effect a little bit more deeply, causation gets really tricky, right? And even philosophical, because we often can't see causation directly. We can only infer it. And so that's why there's so much debate about what it really means to say that something causes something else and how we know when it's a true causal process that's actually taken place. So different disciplines and even, different generations of scientists, um, they have developed their own way of thinking about defining causation. And many of these questions about it are still really kind of hotly debated, even within philosophy and certainly other scientific fields as well. So let's start with this idea of the counterfactual paradigm. So I'll give this example. So let's take this scenario where we suppose a child falls from a tree and breaks their leg. Right? So by observation, we infer that the fall is what caused the leg to break, right? And that actually seems pretty reasonable, right? But to confirm this, right, to confirm that the fall is what caused the child to break the leg, we would have to observe that child at the same time and in the same place under the condition that she does not fall from the tree, to observe that her leg does not break when she does not fall from the tree. And this is basically what we would refer to as the counterfactual paradigm. But again, this is totally impossible, right? We can't actually do that. So that's like sort of this parallel universe. And you'll hear me talking a lot about this because this is often what we're doing when we're thinking about epidemiology, is that we're trying to think about, okay, in this parallel universe, in the absence of an exposure, what does that look like so that we can make comparisons? And this counterfactual paradigm, it's really a lens on the world that attempts to understand the role of a particular cause in a controlled universe where we only isolate the cause of interest. Right? So in this case, if you have a set of people with a disease, some of whom are treated, for example, so they get a drug for that disease, and we follow treated and untreated people over time and assess an outcome, maybe mortality, you can ask the question, for those who died and were not treated, would they have recovered if they were treated differently? And then we can ask the question, for those who received treatment and survived, was this treatment actually needed for their recovery? So let's do another thought experiment to see what this might look like for a population using this concept of risk. So risk is something that we think a lot about in population health, where we have for a specified target population and time period, average risk is defined as the number of new cases for a given health outcome during a particular period of time divided by the number of people who were at risk, right? So you have a population, you have your target population, you follow them over a period of time, and you have some people that develop the outcome. So that's the number of new cases, or A, over the number of people that were at risk for a given time period. And then we can apply this to this kind of same concept of risk to a counterfactual model. So again, we're going to get a little parallel universe here, but I promise there's a point and we'll kind of circle back to the real world in a bit. So under this counterfactual model, let's say that we want to estimate the causal effect of a wildfire event on outcome A. And outcome A could be anything. It could be deaths, it could be injuries, it could be hospitalizations. But to do that, we need to observe the risk in the same target population under different exposure conditions at the same time. So in this case, we're saying for A, for our the one example in purple risk, so our R1, we have the number of new cases divided by the total number of population at risk when they're exposed to environment or to a wildfire event, so an environmental exposure. And then we have a no exposure scenario. So R of O, where it's the target population. So you're observing them at the same time period, but under a different exposure condition where they're not exposed to a wildfire event. And so to quantify or estimate a causal, or actually in this case, quantify a causal effect, right? Because it's the same population, we compare two hypothetical risks in the same target population, so the same group of individuals. And so first we consider the risk, again, if everyone in the population were exposed, so that's our R of one. And then second, we'll consider the risk if the same population were not exposed to that wildfire. So that's our R of zero, or R naught. And these two quantities allow us to define measures of effect. So we have this risk ratio, and it compares risks on a relative scale by dividing our R of one, so our risk when that population is exposed to the wildfire, by R naught, which is when they weren't exposed to the wildfire. And we also have this risk difference. So this compares risks on an absolute scale rather than a relative scale by subtracting our risk under the unexposed scenario from our risks under the exposed scenario. And so these are known as causal contrasts because they contrast what would happen under two different scenarios or two different exposure scenarios, one with a wildfire event, one without the wildfire event. And so they're also called effect measures because they're quantifying the magnitude of causal effect of the exposure on that particular outcome. And so here we're defining what makes a comparison causal. So we compare two quantities. Again, our R of one, risk if the population were exposed, and our R naught, the risk if that same population at the same time period was not exposed, right? So they're going through time in a parallel universe, unexposed to wildfire and exposed. So why are we defining something that's completely impossible, right? Because we can't do that, right? We don't have a parallel world that we can take our R naught from and our R of one and then compare those two. But the reason why this is important to think about is because of exchangeability. And this is sort of the fundamental assumption of a lot of the work that we're doing, which is that we can interpret this difference in our parallel universe example. We can interpret the difference between these two risks as a causal effect because we're assuming exchangeability. This means in expectation, the exposed group is comparable to the unexposed group and what they would have looked like had they been exposed instead, right? Everything else is the same between these two groups except the wildfire event exposure because everything else is held constant, right? So then we can attribute any difference between our exposure scenario, our R1 and R naught, we can attribute that to the wildfire. All right, so let's talk a little bit more about exchangeability. So perfect exchangeability is when we can observe the exact same population at the exact same time point under two different exposure conditions, and where the comparison would be completely perfect by design. Again, so in this setting, the risk we observe in the exposed group would exactly match the risk for the same group would have experienced had it been unexposed and vice versa. And so again, because these two scenarios are identical, any difference could be directly or entirely attributed to an exposure. And this kind of conceptual benchmark underlies all causal effect estimation, right? This is what we want to try to aim towards is observing the same population under different exposure conditions and having perfect exchangeability. But of course, we can't actually observe both realities as at once, right? It's not possible to do. This parallel universe thing doesn't actually exist. And that's the fundamental problem of causal inference, right? We have to live in a parallel universe to do that. That doesn't exist. And so in any study, at least one of the two exposure conditions is going to be hypothetical. And so we have to figure out other imperfect methods to try and do that. So how do we come up with this unexposed population or an exposed population, right? That we can compare those two using these imperfect methods and try to get at this whole parallel universe example or counterfactual condition that I've been talking about. And this is one of the reasons why randomized trials or randomized control trials or just generally randomization, they're generally viewed as such a powerful tool and well, a powerful tool for causal inference, but also for exchangeability. Because a randomized trial is trying to ensure that at baseline, our R naught, so our unexposed group, represents what R naught would have been in the exposed group had they not received their exposure. So for those of you who aren't familiar with randomization, I've kind of given a schematic of what that looks like here. But the idea is that you have a sample from your target population. And here, what you do is you assign the exposure randomly across individuals. So this random assignment means that on average, both groups, those who receive the exposure and those who do not, are similar in their characteristics, both measured and unmeasured. If your randomization works, it doesn't always work, but and you probably want to compare those two groups to make sure that they are in fact similar or looked similar. And as a result, the difference in outcomes that emerges between these two groups, we're trying to attribute that to the exposure itself rather than the pre-existing differences or between those two groups of individuals, right? So you're trying to randomize, you have a treatment and control, and then you look at your risk of outcome under the treatment, so your R of one with your R of naught. So again, you can put your question or your responses into the chat on this. But when you think about this idea of randomization, so again, this is where you randomize exposure, you have a treatment, so a group that's maybe exposed to air pollution or any environmental exposure you want to think about, and you have a control group that's not exposed, and you evaluate the risk of outcome under treatment. If it's successful, both groups being compared are exchangeable. Can you do that in air pollution exposures? Can we randomly assign individuals either within or across populations to air pollution, and why or why not? So, and I'll give you a bit of time to kind of write your answers into the chat. So random, and by randomly assign, what I'm referring to that is like, let's say if you're familiar with a randomized trial, or you could take a population and randomly assign individuals to exposure to air pollution in some way, right? And yeah, question or your responses can go into the chat. Okay, so some people are saying we can't do that because it's not ethical. All right, what else? Okay, so there's a lot of talks about the ethics of randomizing people to be exposed to air pollution. It would be really hard to do. So the complexity of doing this, because populations are really big, and trying to randomly assign individuals would be a very, very hard thing to do. So some people are saying yes, we can have separate cases and controls, and I'll talk a little bit about that later. But cases and controls would be sort of if you had cases of your outcome. So that's actually based on your outcome, not your exposure, right? So in this case, I'm referring mostly to, or I'm referring entirely to exposures. Okay, so some people are saying we could model this, but it would be challenging to do in real life. Um, Not ethical. Okay. So I think what I'm seeing is it's not ethical to randomly assign individuals. It would be really complex to do because you'd need to assign whole exposures, and air pollution can travel over space, and that would make it really challenging to ensure that you had one group that was exposed and one group that was unexposed. Um, so I think, usually the answer to this is no, right? It's not, I think, as many of you were pointing out, it's not ethical or really feasible in a lot of ways to randomly expose people to harmful environmental conditions like air pollution, right? You can imagine often one of the things that outcomes that we study a lot for air pollution epidemiology is understanding how exposure to air pollution impacts pregnancy and birth outcomes. And you could certainly ethically, you would never be able to expose a really vulnerable group, like pregnant people or children, to air pollution as part of an experimental design, right? That would not be ethical. We also can't really manipulate these kind of large scale environmental processes that affect entire communities, or realistically, it's it would be, almost impossible to do that. Um, but there are some exceptions. So one is that there are chamber studies where you can test some human physiological responses to different environmental variables like air quality. So these are really limited usually to healthy young adults. So they may not be the people that you're most interested in studying, the most vulnerable population, so elderly people or pregnant people or children. They would not be allowed to participate in those kinds of studies, but if you take healthy young people and expose them to different levels of air pollution in a chamber, there are a number of chamber facilities that exist to do those kinds of studies, but they are they're very regulated, they're very closely controlled, and they're often not capturing the most vulnerable populations that you would want to include in your study. And then the other piece of this is that we can randomize interventions. So we can't randomize exposure to air pollution in most cases, but we can randomize intervention. So, for example, by assigning some households to receive an air filtration system, and comparing health or learning outcomes, right? So there are some cases that we can randomly assign an intervention, and that is in some ways randomly assigning an exposure because you're sort of making the assumption that this intervention is going to reduce exposure or change exposure in some way, usually towards a benefit. And then you're evaluating health impacts under that controlled scenario. So with the intervention versus not with the intervention. But for the most part, we can't randomize. So instead, we're stuck with observational studies in environmental epidemiology where we can't control who gets exposed. So in this case, we're just observing what happens in the real world. And in this case, exposure is definitely not randomized. And so there's really no reason to believe that the groups that we're comparing are actually exchangeable, right? We have a study population here, right? We have some people that are exposed, some people that are unexposed. We're following them over time. And the people that are exposed and unexposed, they may differ in many ways in addition to their exposure status. So not just their exposure to air pollution. So again, in the chat, are there ways in which people living in high air pollution areas of your city or any place that you've lived before are systematically different from people with low exposure to air pollution? So are there other ways that they are different that is not just air pollution? And I'll give you a little bit of a chance to comment on that. And how are they different, right? So how are people that are generally exposed to high levels of air pollution lower? So socioeconomic status is one example. And I'll give you a little bit of time to write your responses into the chat. So work activities, any other existing health conditions. Okay, I see a lot of sort of environmental or sort of occupational exposures in addition to where people live. Modes of travel, food and water quality access, housing conditions. Okay, this is a really good set. Nutrition is another example. So these are some ways in which people are maybe different, or maybe you've observed differences in people that are exposed to high levels of air pollution to people that are very low in any given city. And I'll say we have a take socioeconomic status, which I think has been mentioned a couple of times in the chat and was the first one that was put in. We have a really well-established literature for many places showing that there's a relationship between poverty or socioeconomic status and air pollution, right? This is an example from a global study that was just published, looking at global regions of the world and the number and share of population exposed to unsafe and hazardous levels of air pollution based on the WHO criteria. And the top three regions, or sorry, the top five regions are all, four of them are predominantly low and middle income countries in sub-Saharan Africa, East and South Asia, Latin America, whereas North America and Europe are on the lower end of that. And when you go all the way to the city level, you start to see the same thing, right? So we have studies across many cities in the world showing that higher level of socioeconomic status relates to lower levels of air pollution than in parts of the city where there's a comparison with parts of the cities that are higher SES. Um, and this is because for many of the reasons that you're talking about, it may be differences in housing or land use or structural factors, which are more likely to affect disadvantaged communities than those that are higher income. So again, because we live in the real world, we can't randomize the population and, force half of them to breathe wildfire smoke or, vent tailpipe emissions into their homes. And so we're forced to calculate risk for our two groups, our exposed and unexposed group, based on a substitution population in the real world. But the validity of our estimates of risk depend on the validity of this substitution, right? And I'm going to use a non-air pollution example, but is still environmental, and thinking about flooding. So in Dhaka, this is the Koral slum on the left hand side, and this is the Gulshan neighborhood that's on the right hand side in this picture. And then there's a river that's going through the city, and the river often floods the Koral slum neighborhood on the left, but there's seldom flooding on the other side, right? On this side over here in Gulshan. But of course, there's lots of other differences between the populations living in these two areas, in addition to flooding, right? Things like that are visible from this picture, right? So things like housing quality, and some of the other barriers that exist, or environmental barriers that exist. Certainly, water and sanitation is different between these two communities. And some of the other things that you talked about, maybe things like economy or occupation or waste burning, not visible here, but could be different between these two areas. And so if you want to study, let's say, the health effect of flooding, our substitute for the counterfactual here, like, so if we have our R of naught is people in this neighborhood, our R of one is people in this neighborhood, right? Our substitute of unexposed, our counterfactual, isn't going to really do a good job of showing us what would have happened in our exposed population if they had not been exposed, because they're really different, right? And they differ by lots of different factors that may relate to the health outcome that we're interested in studying. And generally, there's really no reason to expect that the observed outcome in the substitution population is equivalent to the outcome that we would have observed in the target population under the same exposure, right? So we have to substitute a measure of association for the causal contrast or causal effect. So now we're moving from this hypothetical perfect to real world imperfect. And so, for example, we might compare the risk of our health outcome Y in individuals exposed to a flood with outcome Y in individuals not exposed to a flood. And this assumes exchangeability between our two populations, right? By comparing them, we're saying these populations are exchangeable. And confounding is the result of a lack of exchangeability. So without exchangeability, any differences between our exposed and our unexposed groups could be fully or partially attributable to the exposure that we're interested in, right? In this case, flooding, or it could be wholly or partially attributable to other differences between the groups that are being compared. So if we go back to our flooding example, we were talking about how there's lots of different factors, infrastructure, socioeconomic status, water and sanitation, that are pretty major differences and visible, right? And so if we're thinking about that from a confounding standpoint, right? So here we want to look at exposure to flooding and whether or not it impacts injuries. So this is the study question that we're looking at here. If we think about level of urban infrastructure, right, this correlation between exposure to flooding and injuries, right, urban infrastructure is also an important risk factor for injuries. Urban infrastructure also influences exposure to flooding. So any correlation that we observed is probably due in some part of mixing to the effect of lack of infrastructure, or maybe something like socioeconomic status, not just the exposure to flooding, right? So individuals who are exposed to flooding are different from individuals who are not in this example, and so they're not exchangeable. And that's the underlying sort of fundamental assumption of this. All right, so why am I bothering with kind of all this causal inference stuff? So if you're a researcher that's working on environmental health, you have to continually come back to whether or not your study is designed to estimate causal contrasts. How are you defining your exposure contrasts of interest for your study? How exchangeable are the groups that you're comparing? And what do you need to do to improve exchangeability, right? All studies should be designed to estimate causal contrasts. This is the whole point, right? If you're not trying to evaluate causal contrast, there's no point to doing the study. This is the whole goal of epidemiology. And the specific contract of interest, it needs to be very, very carefully defined in advance. So before you start your study, define a target population and time period, clearly define the causal contrast of interest, and find substitutes for counterfactual measures. So I thought I'd just quickly cover a few of the different study designs that we use in air pollution epidemiology to talk about like how we actually do this in practice. So what are the kinds of study designs that we use? With the caveat that I'm giving you a very, very high level summary. So I'm putting about, 3 semester-long classes into about, I don't know, 8 or 9 PowerPoint slides. Um, So air pollution studies, they're often grouped into two categories. So we have these kind of short-term studies that are designed to evaluate the acute or short-term impacts of air pollution, and that may be over, hours or days or maybe even weeks. And then we have these longer term studies that are used to assess the chronic impacts of exposure that accumulate over a longer period of time, months, years, decades, or even lifetimes in some cases. And the health outcomes that we tend to study with these different types of study designs, those also vary substantially. So if we're thinking about short-term effects, we're looking at things like changes in hospitalizations or cardiovascular events or premature deaths or mortality that we're evaluating as part of the something that can be evaluated on a daily basis or a shorter term basis. But for long-term effects, we're interested in understanding the development or progression of chronic diseases over time. So things like the development or progression of cancer or cognitive development or cognitive decline, or maybe overall reductions in life expectancy. And it's not entirely clear cut between these two, but I'm trying to give you a sense of generally the types of study designs and effects and outcomes that we're interested in. So I'm going to start with some of the designs that we use for studying short-term health effects. And again, keeping in mind that there's lots of different iterations of designs at both ecological and individual levels. But I'm going to talk about time series studies and case crossover studies because these are very commonly used in a lot of epidemiologic research. So time series is probably one of the most common measures for looking at air pollution and its relationship with mortality. There's tons and tons of, of time series studies in the literature. And essentially, what these studies are trying to do is they take repeated, usually daily measures of an exposure and an outcome over time. And then they're looking to associate those daily variations in exposure with daily variation in health, right? So they're basically saying we have the same population, right? And we're just comparing that same population with hospitalizations or mortality on different days. And we're looking at that relationship between different days of the outcome and different days and the exposure for air pollution or whatever environmental exposure you're looking at in the time period right before that. Um, and the thing that we're trying, the factors or other things that might influence things like exchangeability for that population are things that are time varying. So things like for an air pollution study, we may care about pollen or day of the week or holidays or seasonal influenza. So things that might vary temporally in that population. And so the advantage of this kind of study design is that it allows us to isolate these short-term effects of, in this case, on the example on the right, I'm showing weekly temperature and heat-related mortality. So it allows us to isolate those short-term effects of temperature on mortality by comparing each day to nearby days within the same location and season. And so again, this, if you're thinking about this from an exchangeability standpoint, it controls for many of the factors or confounders that change over time or change slowly over time. So things like population demographics, underlying health conditions, or other behavioral drivers of mortality, since those factors are unlikely to vary meaningfully from one day to the next, right? Because you're looking again at daily or weekly counts. Another example is the case crossover study design. So this uses time series type data, but instead of comparing populations over time, this design compares individuals to themselves. So in this type of design, an individual's exposure immediately before a health event, so the case or index period, is compared with their exposure during one or even more control periods at other times where the event did not occur, but the other conditions were similar. So the nice thing about this type of design is that it controls for a lot of different things that could otherwise confound our results. So things like long-term time trends, seasonal patterns, or personal characteristics that don't really change over short periods of time. And because each person or each individual is essentially compared to themselves, those time invariant factors drop out of that comparison. So the control days here represent the counterfactual exposure experience of each case, independent of the exposure on case day. And there's a bunch of different strategies for selecting these days. So unidirectional and bidirectional strategies can introduce bias from different sources. So things like time trends and seasonal patterns that are not independent of the control day of selection. Because remember, we have days that the event occur, and we're trying to find other days where the event didn't occur for that individual from comparison. So a lot of times, if you're looking in the literature, you'll see something called a time stratified case crossover design, which is generally viewed as the best approach. And this is where control days are selected at the same day of the week, month, and year as the case day. So that's a common way that you'll see people trying to deal with this kind of challenge, right? With this, the biases that can be introduced from different time trends and seasonal patterns. Right. In terms of long-term effects of air pollution, there are lots of different study designs that are used, and you're probably familiar with some of these. So ecological studies, cross-sectional studies, case control, cohort studies. Um, And I would say there's, from a historical standpoint, a lot of the early evidence on the health impacts of long-term exposures came from ecological and cross-sectional designs, but then which tend to be they're less resource intensive. They require less data. They are a bit, in some ways, no study is easy to do, but they're a little bit easier to do than some of these really long-term follow-ups where you need long-term data for your population. Um, and case control and cohort studies, those came a little bit later and are generally considered better for causal inference because they capture this temporality between your exposure and your health outcome. Right? So ecological and cross-sectional designs, they don't capture that temporality component as well as case control and cohort studies, but case control and cohort studies they're a lot more intensive. So I'm going to go through two examples because I don't have enough time to go through all of these designs. Again, you're welcome to dig into this more with some of the reference books that I gave at the beginning. But I'm going to talk about ecological studies and cohort. And in part because I think they're the most intuitive, but also because they're quite commonly used in environmental epidemiology. All right. So ecological studies are studies where the unit of observation is the population or a community or group. So in this case, your unit of observation is not individuals. It might be like an entire city might be your unit of analysis, or a township, or a community, or a village. And then your health outcomes and your exposures are measured in the population or community. And then you evaluate their association or effect on health, a relationship with health outcomes. So here, your exposure estimates are really a proxy based on the average exposure in a given population. So I'll give an example here. This is an ecological study that was published in the New England Journal of Medicine. Now it's quite old, it's from 2009. But this is looking at changes in life expectancy in the 1980s and 1990s at the county and metro areas in the United States. And it's plotting that against the reductions in PM 2.5 concentrations. And so this slope that's being estimated here is showing what's the change in life expectancy, or the relationship between the change in life expectancy and the reduction in PM 2.5 at the county level. And so in this case, we're seeing that as air pollution reductions are larger, so moving from 0 to 14 micrograms per meter cubed, you see that there's a larger change in life expectancy in these counties. So the challenge with this kind of study is that you can't actually establish that the individuals who experienced lower air pollution were the same as the individuals who experienced increased longevity, right? So this is what we call the potential for ecological bias here, right? Life expectancy improved and air pollution was reduced, but are the people that were exposed to air pollution, are those also the same people that experienced increased longevity? And assuming that it's assuming that the methods of measurement and exposure and health outcomes is the same across all of these populations. And you also don't know whether people exposed were also those that experienced, yeah, again, that sort of that longevity piece, that reduction in mortality over time. So this is one of the challenges with these types of or this is the main challenge with these types of ecological studies. A cohort study is really good to know about because it's generally been foundational to epidemiology as a whole. So a cohort is a group of people with a defined set of characteristics who are followed over time to determine things like, incidence or mortality from a disease or some other outcome, right? And so cohort studies are generally viewed as being one of the most robust study designs because they follow individuals over time and they allow us as researchers to establish this temporal sequence between our exposure and our outcome. So specifically, we know that exposure is happening before the outcome, right? That's really important for causal inference. If the exposure happens after the outcome, then the exposure cannot cause the outcome, right? But the challenge for this is you need a really large sample size. And for outcomes like the development of chronic disease or mortality, you have to follow them up for a really long period of time, and that can get very, very expensive to do. So there's high costs and high complexity to this type of study design. So one of the foundational cohort studies in air pollution epidemiology is called the Harvard Six Cities Study. So this study followed adults living in 6 US cities with different levels of air pollution to examine how long-term exposure affected mortality. So people were enrolled in the 1970s. They were followed over a period of 15 to 20 years, and then they also collected really detailed information on other types of risk factors. So things like smoking and BMI and occupation. So things that might influence exchangeability between people that were exposed to higher versus lower levels of air pollution. And you can see here that they estimated the risk for different cities with, oops, get my cursor here. They estimated the risk for different cities with different levels of air pollution, which here translates to about I guess about a 25 or so percent higher risk of mortality in the most polluted city compared with the least polluted city. But because they tracked individuals over time and associated their mortality outcomes to prior air pollution exposure levels, this is a classic example of a cohort design. You can also create cohorts retrospectively using already collected data. So here we obtain data on vital statistics and cause of death for neurodegenerative diseases from the Canadian Vital Statistics Database for a period of about 2 decades. And then we were able to assign high resolution estimates of ultrafine particle number concentrations and size to participants' residential postal codes using a 3-year moving averages. And then we could use Cox, a type of mortality estimate, to estimate the hazard between long-term exposure to UFP concentrations and mortality from different neurocognitive outcomes. But in this case, we were doing this retrospectively. We weren't starting a cohort back in 2000, starting the study back in 2001. We were able to take an existing cohort and assign exposure based on that period and having them followed over time. So again, we know exposure happened before the period of follow-up, and then we could evaluate that over a period of time. I'm just going to briefly, I don't want to run out of time, or I want to make sure that there's adequate time for questions. So I'll just briefly mention that I think another area where there's been a lot of interest in air pollution epidemiology, and particularly for the Health Effects Institute, which has started funding studies in this area, is on quasi-experimental designs. So I talked about experimental designs, which are things like chamber studies in healthy participants, where you might look at physiological responses to things like wildfire smoke or heat. You could do a randomized trial of different types of interventions. Maybe you have air filters, or in this case, it might be looking at things related to heat exposure, like climate adaptation strategies. But quasi-experimental designs are when exposure is not assigned by the researcher, but for example, you may measure health outcomes before or after a policy or a program or a wildfire or an extreme weather event that potentially changes environmental exposures. And ideally, you have some kind of control group that was also exposed. Um, this is one example of a study that we did in Beijing. So this is both ecological, right? So it's measured at a population level, not at the individual level, and it's quasi-experimental, where Beijing introduced a clean heating policy to shift townships or to shift villages from coal to a cleaner source of energy. And we could evaluate, in this case, heart attacks, so acute myocardial infarction, over time at the township level, and analyze the difference in the outcome, the difference in heart attacks for people that were enrolled into the policy or townships that were enrolled into the policy versus those that were not. So again, here, everything, this is an ecological study. Everything is at the township level. We have townships that were considered exposed if they had the majority of their villages enrolled into the policy. We estimated incidence of heart attacks, again, at the township level. So the township was our unit of analysis. And then we compare these groups over time. So again, I'm don't expect or I'm not going to go through all of the differences between our policy exposed and policy unexposed groups, but here Beijing is huge, right? There's millions and millions of people in Beijing, but our unit of analysis is the township. So here, right, we only have 59 townships that were not treated by the policy, 75 that were treated by the policy in 2016, 17 that were considered treated in 2018, 2019, and we're comparing the different characteristics for our different townships at the baseline assessment, right? So this is our unit of analysis is at the population level. Um, so my question for you, and feel free to put this into the chat, what are we assuming about exchangeability for our policy treated versus untreated townships? Okay, so if you think about exchangeability, right, we have our treated, so those that were in this coal to clean heating policy, they received electric stoves, and those that weren't. So what are we assuming about exchangeability in these treated versus untreated townships? Right? If we want to compare outcomes over time, what are we assuming? I'll give you some time to put this into the chat. No responses so far. If you're trying to compare a group of townships that went into a policy with a group of townships that didn't go into a policy, what are we assuming about exchangeability for those treated, so in the policy and untreated groups? So one response is independent conditions for each group. Feel free to tell me a little bit more about that. Okay. Yeah. So the response that just came in that changes after the treatment begin will be associated with the treatment. I would change the idea of that is right on. I'd change the wording to that a little bit, right? So we're assuming that the untreated potential outcome trend over time for treated townships would have matched the trend observed among the comparison group had treatment not occurred, right? So if we followed our treated group over time, right, that trend would be the same had that the trend would have been the same as those who were not treated. So we kind of go back to our parallel universe here to see what happens to a treated group of townships in the absence of getting the policy. But again, of course, we can't do that, right? Because we can't compare what would have happened uh, because they were treated, right? So we this is this idea of this counterfactual. But what we can do is, in this case, we can compare pre-policy trends for the outcomes over time for our different treatment groups. So this is a way of seeing whether or not we think we have exchangeability between our two groups, right? Whether or not we think this assumption is a valid assumption. But of course, we're not able to do that in real life because we don't have the ability to follow that treated group over time when they were untreated, right? And so this is what we found in this study, which is we found that the clean heating policy, it reduced township AMI incidence. Um, I'm not going to spend time on these results here, but what I want to just again point out, this is an ecological study. It's also a quasi-experimental study, right? So you can combine these together into one, you can have multiple types of study designs, right, that contribute to a given study. But in this case, again, our unit of analysis is at the township level. It's not at the individual level. And this is what makes this an ecological study, right? And we don't know, and you may have already been thinking this, we don't know whether or not the individuals that had the reduction in heart attacks were the same individuals that were exposed to the policy. So this is the assumption that we're making, and we're trying to sort of make a strong enough case by looking at these parallel trends before the policy and after the policy in our outcome over time. Okay, so I just want to highlight quickly the importance of this kind of work. It provides really important insights for decision makers that are used for influencing things like the US EPA developed national air quality standards, China's air quality standards, the WHO guidelines. We use a lot of these concentration response studies that form a basis for quantitative risk assessment. I think you're actually going to be talking about that a little bit in the next session that's presented in 2 weeks. And these concentration response estimates, they underpin a lot of the risk assessments and burden estimates that we do. So when you see things like the Global Burden of Disease study and these estimates for how much poor health does air pollution cause, and you compare it with other health outcomes, it comes from a lot of these types or it comes from not a lot, it comes from all of these types of study designs. And even studies like Canada, so we have really low levels of air pollution. They demonstrate that health impacts occur even at these really low levels. So, you can use the range of exposures that are experienced globally and put those together to understand this full picture of the relationship between air pollution and health, which is used for a lot of different types of policy and public health guidelines. And I think what I'll do, I'm just going to end here. With some of the key take-home messages from this, every study in environmental epidemiology should be designed to establish causal effects, right? So you want to think about as you're designing your study, you want to design it so that you can estimate the causal effect of your exposure on the outcome, right? The counterfactual model is our ideal. This is what we're trying to achieve. And exchangeability is a really central challenge to that. So this is something that you want to be thinking about in relation to your causal contrast. So if you have your different exposure groups, how exchangeable are there? Are there your exposure groups, and what other information do you want to try to collect to make sure that you can make the case for exchangeability? And again, despite a lot of the imperfect methods that we use, the science really shapes policy and is used for protecting population health. And I'm happy to open it up for questions in the chat. Victor, I don't know if you want to lead that, but I can take a few minutes to do that.
Yes, yes. Thank you, Jill. So I will moderate the Q&A. Thank you for that presentation. I think you covered the bases in the time available. It's one of those really challenging sort of topics when you think about a counterfactual. And as you alluded to, we don't have a parallel universe to sort of where air pollution does not exist and stuff like that. So thank you for that. And you started very well with saying there is no perfect study design. I wish I had had that during my graduate school. I would have had a very interesting discussion with my then advisor. We are always chasing precision and accuracy, but yeah, here we are. So I will look for your questions. Please drop your questions in the Q&A. I will start with the first couple of questions that I see. And I think the first one from Heptamu Ainu is something you actually answered in the course of the presentation. He was asking if interventions are ethical. But I'll combine that with another question that came in from the chat from Batra, giving a real practical example. So he says in his country, which I think is Cameroon, informal welders, so they use these masks while they are welding. So he was wondering whether it would be ethical to randomize a study where you have a group that is using the mask and a control that's not using the mask.
Yeah, I mean, so I'm not an ethicist, but I think, usually what you wouldn't allow people to design a study. So if I'm reviewing a proposal and it's saying, look, standard practice is to wear this protective mask while welding, right? And so what we're going to do is we're going to remove the mask from some individuals. That would not be considered an ethical study. You'd have to make the case, right? If you're going to try to do something like this on the occupational health side, you'd have to make the case that, you have a welding mask and maybe you have another type of mask that's even better, right? And so you're trying to understand whether or not this better mask, right? If this provides a health benefit or an exposure benefit to your population. But for those kinds of things, you would certainly have a very, very extensive ethical review process just to make sure that you're not reducing the level of protection that your worker population is already experiencing with the welding masks that they're using.
Yeah, that makes sense. So, shifting gears to another question from Heptamu. So thank you for the presentation. He says, in LMIC's data is rarely collected at the same time. So environmental data and health data he's referring to. So his question is it reasonable to use satellite-based data to integrate with health outcomes, health outcome data to estimate the effects of air pollution on health outcomes? Or do you have any scientific advice on the issue?
Yeah, so that's a really good question. I think so, and I will say I know I flew through the section on study designs, and again that could be like 3 courses. And so one of the things that I didn't get to talk about was studies that are using satellite data, because I think certainly there's a number of, if you scan the literature, you'll see lots of time series studies that are using satellite data as the measure of air pollution. And I think a couple things to think about if you're designing your study using satellite data. So the first is think about, like, for the health data that you have, do you have a large enough exposure contrast to estimate health impacts? And what I mean by that is that satellite data are a really useful tool for air pollution, but they are certainly not capturing a lot of the local levels of pollution that drive variability, right? So it may be the case that if you look at your satellite estimates of exposure for your study population, you actually don't have enough variability because it's estimated at a spatial scale that isn't going to allow, right, to look at the relationship between air pollution, exposure, and an outcome. You have to have people with different levels of exposure. If everyone's the same or almost the same, then it's going to be really hard for you to estimate, or impossible for you to estimate the health impacts, right? Because their exposure is going to look like it's identical. And actually, we have this challenge with PM 2.5 in the Canadian context. Our PM 2.5 levels are very, very low. And so if you look at, like, the city of Montreal, for example, the difference in exposure to PM 2.5 for some studies, like a hospital-based study in a particular neighborhood, for example, everyone's pretty much exposed to the same levels of PM 2.5. in that spatial area. There are no exposure contrasts. So I would say if you're working with satellite-derived data, probably one of the first things that you want to think about is, do you either spatially or temporally have enough variability in exposure to look at health impacts? The other piece that I'd pay attention to with that is again this temporality question, right? Are you measuring exposure before your health outcomes, at the same time, or after? Because again, remember your exposure, if you're thinking about causal inference, your exposure has to happen before your health outcome. So if it's not, and you measured exposure afterwards, then make sure that you can make a really strong case that that exposure or those exposure contrasts were the same before the health outcomes were measured. So just a couple of things to think about if you're doing a study with satellite estimated data. Oh, and the third thing just being like it's not capturing obviously a lot of the environmental exposures that are happening more locally. And so think about whether or not that is going to influence your study or bias your study in some way. Like, are there certain exposures that you're not capturing, and how might those affect the exchangeability for your populations?
Yeah, so possible, but with a lot of caveats. You really need to think about what you're looking at in terms of variability in exposure.
Yeah.
And I think we've sort of stressed in a way how satellite data can be applied in the course of this training series, both for exposure assessment and actually air quality monitoring. Um, so, Habtabu, you can also refer to the previous sessions as well, or more about, satellite data and the use, its application to health studies. Um, I see a new question here from Jamil saying, in developing countries, how do we adapt to the causal framework to evaluate the effects of air pollution from unregulated and informal activities? This is an interesting one where information about them is sparse. I would even argue is not even available. So, what do you think about that? How can we adopt this framework for studying air pollution in unregulated and informal activities, which is a big chunk of, in any city you can think of, any capital city in Africa, a big chunk of the activities are either unregulated or informal.
Yeah, I mean, I think the sort of using the framework that I presented in terms of, thinking about exchangeability is kind of the key component to all of this. And I think that should be adopted to any study. It doesn't matter if that study is being conducted in a lower middle income country or a high income country. Like that is the framework that you want to be using because again, our goal is always to estimate the causal effect of exposure on an outcome. And so it does, again, place shouldn't matter, right? Like that should be your goal no matter where you're conducting your study. I think the challenge is that if you're working in a context where the data quality or the data availability may have a different set of limitations, I think this is something that you want to consider as an investigator of, A, are there ways that I can conduct this study so that I can meet some of the criteria that I was talking about in this talk, right? And probably some of the other talks that you've been listening to as part of this series, right? In that if you don't have data that, let's say it's a vulnerable population, an occupational population, or it's a population that is exposed to some kind of unregulated industry, right? if if you don't have data on the exposure, right, or you don't have data on the health outcomes for that population, then you have to either go out and collect it or you can't do that particular study, right? So I think this is where if you're thinking about I'm trying to think if you're like the example was it was specifically looking at unregulated air pollutants from particular industries, right?
Yeah, so
Yeah.
informal activities basically by the roadside, like the welders and stuff like that.
Yeah.
No, so not
So
formalized industry. Yeah.
yeah. So again, I think if you're conducting that kind of study, if you're looking at informal workers and you want to understand occupational exposures and their relationship with health outcomes, then you're going to have to think about, all right, if I enroll these workers in my study, right? To try to maybe the first step is just understanding what their exposure looks like, right? What are the levels of exposure? You know, are they high? Are they low? Maybe you do source apportionment on those exposures to understand, the chemical composition. So I think that's always just a good first step is understanding what the exposures are. Now, if you want to look at health impacts, you have a few different options for that. One might be that you enroll a group of informal workers, you measure their exposures to air pollution, and then you measure a set of health outcomes that you care about. And you do that using the variability in exposure that the workers have, right? So your contrasts for exposure come from, variability in the jobs that they're doing, for example. But again, you may have an exchangeability problem that you need to think about because if you're taking workers with different jobs, what are the other things that would influence their exposure, but that are also related to the health outcomes that you're studying? And so those are the other types of variables, if you're doing a field-based study, for example, that you might want to try and capture. So again, anytime you're making a comparison between individuals or populations that have different levels of air pollution exposure, you want to think about these other factors that may influence the level of exposure, but that may also influence the outcome. And you want to try to account for those factors, right? Those are the confounders. And so you want to think about those because if you don't, then, all or partial, a partial component of your estimate is probably not attributable to air pollution. It's attributable to something else that you didn't measure.
Yeah, makes sense. So we have about 5 minutes. I'll take final three questions, one in the Q&A and two in the chat. So Kevin is saying, which in your view will you say influences health policies at the top, environmental epidemiology studies that use ecological or cohort? Which of these one would you say influences health policies most?
Yeah, I mean, cohort studies, as I was talking about, like cohort studies are by far the strongest design, right? So ecological studies are often, they were used as sort of a first approach, but they have a lot of, I think I talked a little bit about the challenge with ecological studies is you don't necessarily know that the people exposed to air pollution were the same people that developed whatever outcome you're evaluating, right? So this ecological fallacy. But cohort studies, they have a lot of important strengths in that you follow people over time. You know that exposure happened first, or a well-conducted cohort study. Those address a lot of the limitations of an ecological study, are a much stronger epidemiologic design, but they're also very, very expensive and time consuming to try and carry out those kinds of studies. Again, all studies have their set of limitations, but from a policy standpoint, the cohort studies really drive a lot of our confidence that that these estimates are or we they tend to be the ones that inform policy more. And not just one
Yeah.
study, right? It's a set of studies as a whole. So, I mean, one of the things that I'll mention, and I'm sure Pallavi has things to say about this as well, given her work on this early on with HEI, is that there were lots of people. We had lots of cohorts that had been done in Europe and in North America, and we didn't have a lot of cohorts that were coming from the rest of the world and in places where people were exposed to much higher levels of air pollution. So there was huge interest for a long time. Now those studies are coming out, but I remember, for example, for China, there was a lot of interest in these cohorts in China when they were going to come out so that there would be estimates for these health impacts at higher levels of exposure. And so you're really trying, it's not just one study, you're looking for a number of different studies in different populations. in different with different levels of exposure and different health outcomes, and you're bringing all of that information together to inform policy decisions.
Yeah, so cohort studies would be ideal, but not just one, but a suite of studies. So final question on the chat. For young researchers conducting epidemiological research in locations that are not covered by ground sensors, uh, but using handheld sensors, what can be used as a reference for data validation when you're using satellites, given the limitations that you've mentioned?
So I know I'm trying to understand what satellite sensors are.
So I
Satellite,
guess it's just
like
referring
the
to
satellite data.
satellite data, yeah.
Um, yeah, I mean, so I think uh, uh, without having the detail of kind of what's known by or what's meant by handheld sensors, um, so reference data without knowing. I mean, a couple thoughts on this, and I know I'm sure these are things that Ben Barrett probably talked about in detail in his talk, knowing that so he does a lot of work with low cost sensors and using those for air pollution estimation. So I would definitely go and look at Professor Ben Barrett's talk. But I think, I think for if you're thinking about doing a study using some of these sensors, um, if you can place some of the sensors, so in an ideal world, if you're, let's say you're working in a city that has reference monitors somewhere in the city. So I'm assuming that you're a researcher at an academic institution or some kind of government researcher institution. Um, or government institution with a research component to it. So what you would ideally want to try to do is take your low cost sensors and place them next to some kind of reference quality monitor that exists within the city where you're doing your measurements, right? That would be the ideal scenario. Um, I think if you're not able to do that, you have a low cost sensor, you don't really have any way of comparing that. The satellite sensors aren't going to, or satellite data aren't going to work for that. Obviously, if you don't have a reference monitor available, I think what I would recommend that you do is know about the sensor that you're using. So dig into the manuals, dig into the literature to try to understand how accurate is that sensor, what is the range of error that you would expect at different concentrations, and make sure that you have that information going into your study. Because what you don't want to do is take a bunch of measurements and then kind of figure out afterwards that all of the measurements that you were doing were the levels that you were observing were kind of within the error range of that monitor. So your comparisons aren't really going to bring you a lot for evaluating health impacts because you don't know the error in your contrast for your exposure is going to be larger than the exposure contrasts that exist in the real world.
Thank you. So we are at time. So thanks, Jill, for that. So it's meant to be an overview for most of our participants, but it really went into detail in terms of the challenges there in air pollution epidemiology. So I'd like to thank you for your time and for attending this session and for being um, very on point with your remarks. So as we finalize, I just want to acknowledge our participants. I think I've seen around 21 different countries represented in the chat and in the introductions. It felt a bit like a mini World Cup. We have people from Nigeria, all across Africa. I've seen Ecuador, Guatemala, USA, India, Mozambique, Kenya, Uganda, Nigeria, just to mention a few. So thank you all for finding time to be with us. Before you leave, we have a survey that we would like for you to take. This helps us sort of um, understand, what you like about these sessions, how we can improve them in future. So please do take that survey. The link is shared in the chat. And before we close, I'd just like to make one quick announcement. We have a session tomorrow, which is a webinar in the run-up to the Clean Air Forum. We'll be looking at the health case for clean air investments in Africa. It's at uh, 2 p.m. GMT, it should be 5 p.m. Nairobi time where I am. So we would like for you to just remind you to register for this conversation, have a listen in. We are doing this in collaboration with the Africa Clean Air Network, Makerere Lung Institute, the South Africa Medical Research Institute, and the Pan-African Thoracic Society. So we look forward to seeing you at that conversation. In the meantime, do enjoy the rest of your day, evening, afternoon, or morning, wherever you are. And once more, thank you for your time. And we look forward to seeing you at the last session in 2 weeks' time on June 30th. So with that, we draw this to a close. Thank you all, and have a nice rest of your day.